interview with Dr. Jack Cruz. And the first topic is that under the background of the precision oncology and where the personalized prevention be the future direction of the prevention for the breast cancer and why.
Yes, I think we really do need to do more about tailoring breast cancer prevention towards individual women. And that includes not only preventative therapies and interventions like exercise, but also simple things like screening. So one of the proposals we're trying to develop is when a woman comes for her first screen, she should get a risk assessment. And from that, one will be able to make better decisions about the need for future screening. Should it be more often? Can it be less often? And ultimately, can we even find women who don't need screening because the risk of breast cancer is low? But at the moment, it's more focusing on who's at high enough risk to think about interventions and who is possibly at low enough risk that screening can be done less often. I think this is really important, and we've done some work in Manchester with Dr. Gareth Evans, and women are actually very keen to know about the risk of breast cancer. It's something that's likely to be very well received.
Okay, let's move to the next topic. Okay, and for the patient who carry the BRCA1 and the BRCA2 mutation, and should we actively encourage them to take the preventive mastectomy? And if not, what the prevention measures should we take on this group of the people?
Well, women with these mutations are at very high risk of breast cancer, typically of the order of 60% lifetime risk. And it's higher if they've had a family history of breast cancer, which is the way many of them are diagnosed. If there's a strong family history, they'll get tested. So in those cases, the risk can be as high as 80%. At that higher risk, mastectomy becomes a very attractive option at a certain age. The other issue which is maybe a little bit less drastic, is whether there should be an oophorectomy. That is, should the ovaries be taken out? Because these women are also at high risk of ovarian cancer. So it makes sense for that. Plus, taking out the ovaries reduces the risk of breast cancer by about 50%. So surgical approaches seem to be particularly attractive for these women because they're at such high risk. And the only real analogy is a little bit like the APC gene for colorectal cancer. This is, again, a very rare gene, doesn't affect a lot of individuals, but typically individuals that have this mutation get a lot of polyps. By the time they're 20 or so, they have 100 polyps in their colon, and they'll almost all get colorectal cancer. So there it's very easy, I think, to say surgery is probably the right approach. For some of the BRCA carriers, the risk is lower, particularly if the family history is not so strong, and it depends a little bit on the mutation. Some of these mutations carry more risk than others. And the next most useful thing to consider after surgical things is if they're premenopausal, tamoxifen is the most effective treatment for premenopausal women at high risk. And for postmenopausal women, it would be an aromatase inhibitor like anastrozole or exemestane. But I think surgery is still probably the first option for those at that higher risk of breast cancer.
Yeah, thank you. And the last topic is that according to your expression and the clinical practice, and what kind of the tumor reduction technologies may help the personalize the breast cancer prevention?
Well, one of the most important risk factors for breast cancer is actually mammographic density. It also has the problem that dense breasts tend to obscure the ability to see the cancer. So for younger women that are at high risk of breast cancer that have dense breasts, using MRI as a screening technique is one thing that's already being adopted many places. And it's helpful, I think, to begin to detect these tumors earlier. The big challenge with breast cancer, which is different from the cancers where screening has been particularly effective, notably cervix cancer or colorectal cancer, is we cannot identify the precursor lesion. We don't know what's going on. We know there must be precursor changes because radiation at age 20 produces breast cancer in women aged 50 to 60. So there are early changes ongoing. A challenge, I think, is to be able to identify these in a reliable way. We're not able to do that, with the exception of certain benign things like atypical hyperplasia or lobular carcinoma in situ, which are not considered to be cancer, but certainly do benefit from preventive therapy and are very useful. Again, we only diagnose these typically because of a breast calcification seen on a mammogram. So there's a lot of work to do to figure out how to more accurately identify high-risk women. I can't give you a full answer other than to say it's a very important area and we're beginning to make some progress.